Welcome to this session on best practices on the patient health record and platform that have been developed in 3 countries that we're going to be reviewing to facilitate patient access to its health information. I am Charles Perizot. I'm the chair of IHE Services in IHE-Europe, which is the operational branch of IHE, dealing with and supporting and helping deployment projects and customizing testing for IHE and other standard-based specification for information exchange. So we want this morning to welcome the first of our speakers, Hervé Barge, who is since 2012 the CEO of the Luxembourg National e-Santé program. He is the one who helped launch and deploy and grow this project for the past 9 years. So a lot of experience that is with him, and with him is Samuel Danhart, who is responsible for interoperability at this same program in Luxembourg. Hervé?
Yeah.
Start.
Okay. Thank you, Charles. Thank you for hiring us to present our health service platforms. We present the slides, yeah. Sorry. Okay, since 2012, the Health Luxembourg Agency has been working as a mission to develop Luxembourg's health information system. And the main objective is to develop an IHE in production, the DSP, Dossier de Soins Partagés. And at the beginning, we have chosen to develop this IHE around the IHE profile. The DSP is in the center of our services, but at the beginning we develop a central component with approach, urbanization approach, and for example, for directory service, we have some we have a MPI for patient, HPD for healthcare, and all the system of security, traceability, authentication service, and the terminology server. And around this urbanization component and security component, we develop the DSP and also many services for pseudonymization, for example, anonymization, médecin référent, it's to follow patients with chronic disease, and for this, we have all the services here for SAFE. It's another European project. Now I think it's better that Samuel Danhart, head of interoperability, will present the evolution and integration of IHE profiles at agency level.
Thank you. So I will follow up on this schema representing, as Hervé explained, on the left the urbanization component like the MPI, the HPD, the security, and we have in blue squares different services that we offer on the platform. For, as he said, we have the DSP, of course, we have terminology servers. We built some services because of the COVID pandemic. But once we had the urbanization component, once we had the IHE profiles plugged in at the right places, we wanted to go further and to develop our platform. Because if it's only living on its own, it's not that interesting. We really wanted to work on 2 axes. The first axis on the left was the industrialization of our platform, and the other axis was the amplification of the usage and the amplification of what we can do with our platform. So I will go a little bit in details on the different things, but as you can see, it's not a direct path to the goal, the upper right goal. Sometimes you have to wait. Sometimes you don't have all the green lights. So the good thing is you can work on both axes. When one is blocked, you can work on the other one. So in the end, yeah, we are growing as we can, and it's not always as direct as we would like to do. So two main axes: industrialization and amplification. For example, in terms of industrialization, once we launched the platform, we wanted to have a real feedback of the usage, because we have our own idea here at Agence, but of course it's not the real world usage. So we do survey, we do continuous improvement. For example, we learned that 72% of the patients would use the DSP if they had the right information. What is it? How to use it? So it's really good insight. So we can work on the communication, we can work on the usage, we can enhance what is not good enough. We are building a test laboratory. The idea is that any industrial who wants to connect to one of our services will go through a neutral conformity assessment process to ensure that you have quality, of course, in the services that we provide and that the new vendor can provide, but also that our test lab follow quality procedures, so the game is fair for everybody, the game is neutral for everybody. And something that will be in the next weeks, in Luxembourg, there was a decision to, based on the European interoperability framework, to have a national interoperability framework, and then to create a sectorial interoperability committee, one for health, for example, and Agence e-Santé will be part of this committee, will be head of this committee. So here as well, we want to have the platform industrialized with the best practice, with what is expected in terms of interoperability from the European level, and how maybe some of our platform can be used, some of our practice, some of our ideas can be taken in other domains, like social security, CT, juridic, and so on. So this was the part of the industrialization of our platform. And then we wanted to amplify it. So one idea is to use the building blocks we have. We talked about the MPI and the healthcare provider directory. So for example, during the COVID pandemic, Luxembourg built COVID centers, and we proposed the centers to make lookups on the MPI. So based on the social security card or just a scan, they have the demographics on the patient. They can quickly fill the information or check the information provided by the patient. We are working on integrating the hospitals with our SSO. So when professionals in the hospital want to interact with the platform or get more information about the patient on the DSP, they don't have to type the login again. That was for the building blocks. We also try to find new use case on the DSP and on the platform. For example, for a patient who have cancer, they can do the test labs. Based on the result, the oncologist can decide to report, for example, a treatment or to confirm an encounter. So it's really useful for the patients. In a few weeks, we will be able to see on the DSP radiology imaging, which is hosted on a national archive, which is another project, not from the agents, but we have here a synergy of one project hosting the image and the DSP who can share them. And also there are new document types coming in the DSP. So far, it was a lot of lab results. I should say 80% of the documents are lab results, specifically because of the COVID. So in general, we have 3 million documents. And now we have, for example, a radiology report are coming, discharge letters are coming, transfer notes, and so on. Another axis is the e-prescription. Using the platform, we want to provide a laboratory, medication, and a little bit later, radiology structured prescription. And it will be linked to a clinical decision system for interaction like drug to patient, and drug to dose. And when we will do the imaging part, we will check the guidelines to be sure to make the best profession can do the better prescription. We are working on vaccination record. So currently it's paper-based in Luxembourg. So the idea is, of course, to have it digitalized, and as well to plug in a decision support system to follow the guidelines and to see with the current patient status, how is the vaccination coverage for this patient, and what should be or could be done for him. And in the end, the final part is we will have a lot of information coming from different sources. There are wisdom in this information, but you have to find it. It cannot be a manual process. It has to be informatized. And for that, we are building a data lake. So the idea is to have this information coming from the DSP, coming from the prescription, coming from the different document types that we can have, and to see if what knowledge we can have, what we can extract from it. The first use case that we will have is for rare disease. So this is our next big project, which is currently building. And if you had to summarize everything in one sentence, I would say, be sure to have a platform with solid basis, with interoperable foundation, so you can share the information, you can transfer the information, and then based on that, create new possibilities, see with the ecosystem what they need, what you can provide, and provide it. So that's it for me. Thank you.
Thank you very much. That's indeed quite interesting, and to see how much progress you've done since you've opened your service in 2012.
Thank you.
We would like now to pass the baton to Johan Hobelman, sorry. Johan is architect and a consultant at MedMij. MedMij is part of the Dutch Ministry of Health, Welfare and Sport. This project started in 2016 and developed a trust framework that is a standard for sharing health information via a personal health environment. So in the Netherlands, MedMij is prescribed for all programs that stimulate sharing of data between the patient and health professional. So we definitely want to know more about this. So Johan, the presentation space is yours. Thank you.
Thank you, Charles. I will share my screen. Let's see. Okay. Welcome. My name is Johan Hobelman, architect at MedMij, and also member of the Data Sharing Coalition. MedMij is the only program in the Netherlands that deals with the communication and sharing information between the patient and the care provider. And it's part of all the national programs to accelerate and to improve the communication digitally with the patient. Very important, MedMij is not a platform as is shown before in the Luxembourg. MedMij is a trust platform. It's a set of requirements, a set of agreements, but we do not deliver services. We have a set of requirements collected in our trust platform. And the purpose is to deliver information to the patient, to persons, to enable the use of personal health environments. And looking at personal health environments, the ultimate target is an environment where you can collect data and manage your own health data. Collecting data that's delivered by care providers, but also delivering data to these care providers. For instance, making an appointment or self-measurements. If you measure your blood pressure, you can share this information with your care provider. But also functional modules, so an agenda to make appointments, e-consult to have consults on a distance, very relevant now in this Corona time, and personal services. It's not only health information is important when you're sick, it can also be when you're a sportsman or whatever. You want to monitor your own health, so you can have a personal health plan, so you can also manage this kind of information. You will share this data with different parties. That can be care providers, like a hospital or your generic practitioner, but can also be the government with other health information. And it can be that possibly your information, you deliver it to research institutes for further investigation. If we look at MedMij, it's a framework for interoperability and integration of information, connecting service providers with each other to share the data. The second part of MedMij is the information, the standards, the models for data structure and interchange. And very important is we do not develop new standards. We collect the relevant standards and we developed all the solutions, all the measure, everything that must be done to deliver privacy by design, to deliver the enhanced privacy and security. And very important, all the exchanging of data is conform the user consent. The user consent is given for a certain purpose. And only with the user consent, you are permitted to share the data. Looking at the base architecture, the MedMij network, the MedMij framework connects service providers with each other. On the left side, you see the public domain with the non-professional users, the public, the patient. And on the right side, you see the healthcare domain, the care provider domain with professionals. You must distinguish these two domains because other laws are relevant. How to use information is different in these different domains. But the end users are not the members of the MedMij framework. The MedMij framework, the members are the service providers. These are the professionals who must meet the requirements of the MedMij trust framework. If we look at the interoperability, we use a standard model developed by NICTIS for healthcare. And you see all the parts, all the aspects of interoperability. It can be technical, on the bottom, the infrastructure, can be software, applications, can be information, but also laws and regulations are very relevant to develop the requirements. If you compare it to a trust framework for other domains, you see the same elements in this framework. So the BLOFT framework is developed by the data is used by the data sharing coalition also for other domains. So if you want to exchange data with other domains, you have to make appointments of all these elements of the framework. Looking at MedMij and this model, this framework, we described all the processes in the architecture based on the roles that we can distinguish, the functions of these roles, and the information they need to fulfill their functions. If you visualize it on another way, on the left, you see the public, the persons. On the right, you see the healthcare domain. And it's always the same steps you must make to exchange information. The first question is, what do you want to do? But the following question is very important. Who are you? The identity of the person who wants to exchange information. What are the authorizations of this person? And then, in fact, sharing the information. If you summarize it, the care provider must make sure the identity of the person to exchange the information. The person always must give the consent, the authorization to the service provider and to the care provider to enable this exchange of data. And then you can exchange the information. This is the architecture. If we have a look at the flow that we developed, here you see the step authentication. So in the Netherlands, for identifying a person, you must use the social service number. There's only one mean that can deliver the social service number, that's DIG-ID. That's the identity provider in the Netherlands. The only one who may process the social service number. Is very limited because the social service number may not be used in the public domain to prevent identity fraud. So we had to develop this OAuth flow. So the next question is the authorization of the person to exchange data, and then to generate an access code, an authorization code and an access code to enable the resource server to exchange information. We use OAuth for this process. And the last step, the exchanging of information based on this access token is between the personal health environment and the resource server in the domain of the care provider. Looking at the details, here you see related to the description as I found in the IHE description, separation of the authorization server and the authorization server. Here you see the same mechanism, asking for the authorization, generating access code and the access token, and exchanging the information. It's the same process. Looking at the standards that we use as MedMij, you must have a secure access to your personal health environment. There we use multi-factor authentication. On the other side, generating the social service number and determining the identity of the person, we're using DIG-ID. In the Netherlands, there's also a couple of alternatives, but DIG-ID is the only means that is allowed to process the social service number. For authorization, as you saw in the flow, we use OAuth 2 and enabling to make a secure connection between the service providers. We use PKI certificates, and the certificates of the government. It's PKI overheid. It's certain certificates generated by the government. Looking at some relevant principles, we also use connection, and for exchanging data, we use FHIR. We separated the authorization server and the resource server, and so we can connect several parties, but also other networks to gather the information. But it's the task of the service provider on the right side to collect all the data to present to the personal health environment. If we look at, for instance, an example of logging, in the Netherlands, for the healthcare is prescribed the NEN 7510, and part of it is 7513, dealing about logging and registering all the events for exchanging data. If you look at this norm, they used several frameworks, and you can relate this, but NEN 7513 registers more than it's described in these frameworks. You can register the persons, the roles, the events, what kind of information is exchanged, or to have a backtrack of all the events. But the non-standard, for example, is the address book we use to connect the systems to each other. We developed a whitelist, and we developed an address book. The combination of care provider and data servers points out to an address of the resource server. And that is for systems connection, but to make it human readable to find the care provider, we developed a connect list. So making this address information human readable. There's a non-standard that's MedMij specific, but it's all based on internet technology and internet addressing of nodes. Having developed this framework, there's a couple of changes coming up. This is the first step. Authentication, as I told you, on this at this moment, only DKD is permitted to use. We're looking for alternatives and to make sign-on easier. Maybe single sign-on, but knowing this is health information, we have to deal with high security levels. And then single sign-on is not always permitted. As I have shown you, we have separated the resource server and authorization server. And we're looking for other ways to have the identity provider to separate the authorization provider as a central service, not delivering it by ourselves, but enabling it for other providers to deliver authorization and authentication. And looking at authorizations, we need the consent of the person to exchange data. So we are developing a service to register the permissions and to reuse these permissions. So the user does not have to give this permission every time there is an interaction, but it can be delivered by a register. To make it more friendly for the user and to need less interaction. This is my introduction in MedMij. Any questions is now.
Thank you. This was a very nice presentation. I think you gave us a very good concept and idea of MedMij. I suggest we go through the third presentation and keep the last 10-15 minutes at the end for question across all three presentations. So you can please put question on the chat, or you will be able to ask a question yourself, that make a note of your questions. I would like to move now to the third speaker in this session about sharing experiences on the deployment of patient health record at the national level. Stéphane Spahni is our next speaker. He's a system architect at the eHealth and telemedicine unit of the University Hospitals of Geneva. Stéphane has contributed for more than 20 years to the establishment of the electronic patient record. First, at the level of a regional platform in the Geneva canton called mondossiermedical.ch, and now for the national EPR platform at the overall Swiss level. Is in particular in charge of the interconnection between the hospital information system and the EPR platform in Switzerland. Stéphane is also highly involved in IHE, being a board member of IHE Swiss, the user co-chair of IHE-Europe, and an active member of IHE Pharmacy. Stéphane, we welcome you and want to give you the floor.
Thank you, Charles. As Charles mentioned, I'm working a lot on the regional platform, but the presentation will focus on the national platform, as the regional one will be replaced by the national one this autumn. So, landscape in Switzerland, we have a national digital strategy since 2007 at the federal level, where one of the key items of the strategy was the setup of a nationwide electronic patient record, patient-centered, under the control of the patient. However, we have a structure in two layers. The federal government can establish laws, application laws, but implementation is delegated to regions and to cantons. So the federal government established the legal framework for the electronic patient record in 2017 with the federal law setting up the guidelines and the key principle of the electronic patient record, leaving then the different regions to implement that. This results in the notion of regional communities, which have to be interconnected each with the others. So we'll have at the end something like that, a certain number of communities and central services, basically a central healthcare professional directory, management of the national patient identifier, and management of national terminologies. The key difference between what we call reference communities and simple communities is that the reference communities also manages patients. A patient willing to open his electronic patient record has to enroll with a reference community, and only the reference communities have a portal for the patients. Healthcare professionals can join any community in Switzerland. But all these communities have to offer the same services and to be interconnected one with each other, so that if a healthcare professional or a citizen is looking at the patient record, all documents are viewed wherever they are in the different communities. Along with the technical aspects is also defined a very rigorous certification process. If a community wants to go live, it has to go through technical certification, in particular through national projectathons, which are organized yearly based on IHE Gazelle tools, of course. And there is also formal certification by an accredited auditor for the service provider, providing the service, the technical implementation for each community. the processes behind the management of the users, of the patient, healthcare professionals, the help desk, all these aspects. Affiliated healthcare institutions have to be partly certified too, and EID providers have to be certified in order to be, in order that the users can use these EIDs for connecting to the electronic patient record platform. Initial planning, the law is from 2017, and there was 3 years implementation delay. So officially, every region had to offer the EPR service by mid-April 2020. And hospitals, primary care, including rehabilitation and psychiatric clinics, had to be affiliated by mid-April 2020. For 2022, it's defined in the law that birth centers and institutions for the elderly have to be affiliated also to one community. Opt-in for all the other care providers, opt-in for the patients. Current status is slightly different. We foresee 10 different communities. Most of them are reference communities. Out of these 10, only 4 are yet certified, and 3 only are live and are registering patients. And there is a decision from the parliament to remove the opt-in for the private care practitioners. It's a decision for the parliament. It's not yet in an application law, so I don't know at which time it will enter into force. But there is a big delay, and probably the 6 other communities, some may be live this year. For sure, some will be live only next year. So basically 2 years delay for some of them. Regarding the patient access to the data, it's really the healthcare, it's the patient record. It's under the control of the patient. And patient access to his patient record through a web portal, the web portal of her reference community. Every user willing to access the portal has to have a certified EID. And we currently have only 3 certified identity provider over Switzerland. Of course, the patient has access, can see any document in his electronic patient record, regardless of in which community the document was published. If you have a provider in another community, you do not see the technical details, the communication between the communities. It's transparent for the users, the patients and the healthcare providers. Patient may tag documents as sensitive or confidential. There are 3 levels: normal, sensitive, confidential. And the patient can decide who can access her documents, or has even to decide, because he has to grant each user for giving him access to his patient record. And he can give access to the normal documents or also the sensitive documents, but never to the confidential documents. He can also blacklist a healthcare professional. That's unfortunately, I do not have it in English, but that's the global architecture of every community. You have the key building blocks. It's fully IHE based. So you have an MPI, you have document registry, you have the healthcare provider directory, and you have the document repository, and you have portals, and you have identification cards for the healthcare professionals, certified EID, strong authentication, 2 factors. And if you are a reference community, you also have to manage or to support certified EIDs for the patients. And portals, you have a web portal for the healthcare professionals in every community. You have a web portal for the patient in reference communities, and you have also technical portals mandatory is to provide the IHE transactions for accessing documents, accessing the MPI, the HPD, and the different services. Regarding the central components, we have a national healthcare provider directory, which is fed by each community's healthcare professional directories. So each user, each healthcare professional to which a patient may grant access has to be described in the healthcare professional directory. Basically, he's described in the HPD of the community he's affiliated to, and then there's synchronizations between the different HPDs in the different communities with the central HPD, so that a patient in community A may grant access to a healthcare professional that is connected to community B, that is affiliated to community B. And there are national terminology services. We have also created a national patient identifier, which is managed by the Federal Social Security organization. This national patient identifier can be used for communication between communities, but it cannot, and between primary systems and the communities, but it cannot be used for any other purpose. And primary systems are forbidden to store this national patient identifier. It's in the law. If you need it, you need to query your community for retrieving this ID in order to be able then to communicate with the community. So rather restrictive for the use of this identifier. It's for privacy reasons that it's strictly reserved to this purpose. Regarding the key IHE profiles being used by the different communities, we are fully based on IHE profiles. So you have, of course, the logging aspects, and with the ATNAs, time synchronization. MPI is by PDQ v3, PixV3, XCPD based documents. It's basically XDS based. HPD profiles, shared value set, cross-user authentication, and we have national extensions for authorization decision request, and for PPQ, and we have for several profiles, we have some national extensions. All these extensions are, of course, supported by the, we have a national Gazelle test platform, which had implemented also the national extensions. Current services are implementing the electronic patient record, but of course, architecture and services are not frozen. There is continuous evolution, addition of new services and content. We are working on the mobile aspects, supporting in the future MHD with the internet user authentication. We are working also as in a pilot for implementing a full e-medication infrastructure. If you are interested, I will present it this afternoon in another session. And national extensions are also being implemented. CMPD, it's the community manager for prescription and dispense, so e-medication. Exchange format CDA based for e-medication, exchange format FHIR based for e-medication, etc. So we are currently mainly XDS and CDA based, but we are moving towards mobile, towards supporting FHIR based profiles in terms of transactions and in terms of content. And that's it for this short presentation of the project in Switzerland. If you want to get more information, eHealth Swiss is the federal agency coordinating between federal government and the cantons. So it's really a national coordination involving all key stakeholders. And you have all the information on their website, with the different the architecture, the different profiles being used, and many other documentation. Thank you.
Thank you very much, Stéphane. Thank you for our three speakers to be perfectly on time. And I would very gladly open the floor to questions. Do we have already questions posted for the presenters? So I have a question, at least a comment on from Everett Sanders on images and asking the question for MedMij about the support of images. Maybe Johan, you want to provide some clarification on that point here.
Yes, no problem. It's important to know that the focus of MedMij is the communication, sharing data between the patient and the care professional, and not sharing information between hospitals or other care professionals. There are other programs dealing with that part and also using other standards.
Okay, thank you. This is a good clarification. I have another question for MedMij, which is who is setting up and implementing MedMij today?
Excuse me?
Who is implementing in terms of deployment? You've spoken of the framework, that's very interesting.
Yeah.
Is that framework implemented, deployed in some hospitals, some regions, some projects? Could you give a little bit of input there?
It's implemented and deployed nationally on this moment. Several programs dealing with hospitals or care providers. It's a couple of national programs in total, about 500 million euros of budget to implement MedMij and other changes in improving the communication digitally between care professionals and with the patient and the persons. It's a program from the government, and we are working with a couple of partners and with service providers, so commercially and non-commercially, profit and non-profit, to implement MedMij in the Netherlands.
Okay, thank you. Maybe we can ask the same question to Hervé. Today, how many Luxembourg citizens have access and do use their national health record?
So I have the case, so I will discuss with
Samuel.
So the
Yes.
question is how many patients have the DSP? So we have the whole population, basically. So we have, that's quite funny, we have 150% of the population having DSP.
Yes.
Because the health insurance covers as well the cross-borders workers. So we have the population from Luxembourg, and all the population coming to Luxembourg to work is covered as well and has the possibility as a DSP and can access it.
Okay, so all of foreigners that are actually working in Luxembourg. Okay.
How well is it used? Can you see the amount of usage?
In terms of usage, we have 3 million, between 3 and 4 million documents for a population of 650,000 around in around 1 year. Yes, in around 1 year. In terms of usage, 1/6 of the patients use it regularly.
And
13%, yeah.
And
That's
then-
an interesting number. I was told a lot by different programs that actually patient on a large population access their record, you know, in a 15 to 20% is already a good number to get people engaged. Stéphane, on your side, I mean, you say that 3 cantons are connected. Do you have a sense of the patient population that is reached there and which is actively using?
Yeah, I do not have the figures of. I only have the figures for the French-speaking community, which groups 5 cantons, including Geneva, but Geneva is not yet connected. This community started 31st of May, and they have about 500 patients enrolled. So in 3 weeks approximately. If we look at mondossiermedical.ch, the platform in Geneva, which is operational since 2011, we have 50,000 patients enrolled for a population of about 450,000 inhabitants. And we have about 10 million documents in the platform in Geneva. So these 50,000 patients will have
more
to
than
move
10%.
to the other one,
Yep.
to the other, yeah.
Yeah.
Yeah, it's 10% of the patients.
And the vaccination status, is that plays that a role in the system? Because
Not yet.
that can be a way to get people involved.
Probably historically we had a completely separate project implementing a vaccination record. And unfortunately, this platform had to be switched off 2 months ago because they had some security breaches. And so there is a plan for having the vaccination status, the vaccination card in the EPR platform, but nothing is yet clearly defined.
Okay, thank you. Are there other questions? I think we've exhausted the questions in the panel. I see MedMij, Johan making a comment that they're working on the vaccination side, like many places.
Yes, for accelerating the use of the personal health environment by the public, we like to enclose this kind of information. Yeah, but it's not defined yet.
Okay.
Can I organize in MedMij my consent for the whole country? So I have images in a university hospital, in my local hospital, and abroad. Can I, if I organize my consent about exchanging in MedMij, does all the other institutions follow that?
It's not part of the program MedMij. There's a separate program dealing with permissions and with consent, and it's MITS. And there's another program, another national program dealing with permissions.
But MedMij has to deal with MITS, I think. So
yeah.
It's only one way.
Yeah.
Okay.
Okay, so as we are discovering, engaging the patient is a challenge because you need to have data, you need to have broad access, you need to overcome a number of policy factors in terms of authorization, authentication, and building and establishing trust. So we see a little bit, I would say, a better explain the various dimension and the breadth and the complexity of providing health record to patients. Okay, so unless I hear further questions, I will conclude this session. Any last minute questions? If none, thank you very much to our 4 speakers and 3 presentations. And please do not hesitate to contact them or to contact IHE-Europe. We'll happily answer your question if we can, or put you in contact with the right people, either on the technical side, the clinical side, or the process deployment side. In IHE-Europe, we're trying to connect all of those pieces, although we are not directly responsible, especially on the policy side. This is a project, a specific challenge and national processes and rules and regulation. Thank you very much for your attention. The IHE Experience conference continue. I want to remind you that 11:30, you have a VIP tour of the Connectathon. Remember that the Connectathon is happening in parallel. We get over 100 systems that are 100 participants and 30 systems that are actively testing. And if you want to know a little bit more how it works and how this is performed and the progress being made, you have those VIP tours at 11:30 and 4:30 every day. Do not hesitate to join those. And you have a lot of other interesting session and that will take you on the world tour on eHealth. So enjoy the conference. Thank you very much and have a good day.